Greetings. Let us learn about colonoscopy. Before you set up the room for a particular procedure, it is a good idea to discuss with the endoscopist what his preference is for that particular patient, whether he wants an adult colonoscope, a pediatric colonoscope, or a slim colonoscope. And when it comes to the type of scope, it is important to appreciate the difference in the insertion tube diameter when picking up a particular scope. Let us look at the insertion tube diameter and the endoscope biopsy channel diameter when deciding which scope should we be picking up. For most adult males, an adult colonoscope, which has a 12.8 millimeter insertion tube diameter, works very well. In women, especially those who have had pelvic surgery, it is preferable to pick a pediatric colonoscope that has 11.8 millimeter insertion tube diameter, and the channel size is still pretty good, 3.2 millimeters. In some patients who have had a relatively fixed sigmoid colon from adhesions, or those who have been exposed to radiation, a much slimmer scope might be a better idea, and this scope is available with an insertion tube diameter of 9.5 millimeters with a channel diameter of 3.2 millimeters. So here is the colon, and when a colonoscopy is performed, our goal is to reach the cecum all the way to the beginning of the colon and document that we reach the cecum. Before we consider doing a procedure, during the evaluation in the clinic, one should decide whether there are risks that outweigh the benefits of colonoscopy. The most common reason for colonoscopy in this country is to do a screening exam for colon cancer or a surveillance exam. Patients who are elderly, above the age of 75, especially if they're frail with serious comorbid illnesses and a limited lifespan, they may not benefit from ongoing screening exams. That is something that needs to be discussed. It has been shown that patients over the age of 80, when they undergo colonoscopy, their risks not only include bleeding and perforation, but also the risk of myocardial infarction and the risk of a stroke increases significantly. This has to be kept in mind. So now let us look at the various indications for colonoscopy, screening being the most common reason for colonoscopy. Screening for colorectal cancer. There are three indications as far as the screening for colorectal cancer is concerned. Patients who are otherwise healthy, starting at age 45 till 75, without a family history, should undergo colorectal cancer screening using colonoscopy. Although there are other methods of screening, in this country, colonoscopy is preferred. Patients with a family history of colorectal cancer or patients with high-risk colorectal cancer syndromes like FAP and Lynch syndrome should also undergo screening, and either flexible sigmoidoscopy for FAP or a colonoscopy for patients with Lynch syndrome should be considered. Again, patients with long history of IBD, inflammatory bowel disease, either in the form of Crohn's disease or ulcerative colitis, those who have had the disease for at least 8 years or longer should have a colonoscopy screening. However, those patients with IBD and primary sclerosing cholangitis, they should get screened the moment they're diagnosed with both of those conditions. So let me take you through some examples. Screening starting between 45 to 75 for colorectal cancer, may find cancer. And here is a picture of colorectal cancer. Unlike the finding of cancer, which is rare during screening, in the same population, you are more likely to see a precancerous polyp or an adenoma. Patients with a strong family history of colorectal cancer are also at risk for colon cancer, and these also should be screened using colonoscopy. Again, patients with long history of IBD, either ulcerative colitis or Crohn's colitis, 8 years or longer, should undergo screening. And in this patient, the exam was normal and they should be screened at regular intervals, maybe 1 to 2 years intervals for long-term surveillance. Coming to the role of colonoscopy in terms of diagnosing a problem, an indication that is diagnosis. So let us look at it. Here is a patient who reports that he has been passing bright red blood in the stool, and one should not think it is hemorrhoids. These patients should be examined to rule out the possibility of colorectal cancer. Other reasons for bright red blood in the stool include hemorrhoids, colitis, angioectasias from the rectum, especially if they've had radiation to the prostate for prostate cancer. Another patient here, this patient stool test was positive for occult blood, and he was also found to have iron deficiency anemia, indicating that he has a slow GI bleed. This patient should also undergo colonoscopy, and one should be looking for either colorectal cancer or polyps. Let me look at another patient. Here is a gentleman who had regular bowel movements, one form stool a day for most of his life, and for the last few months noted change in his bowel pattern, increasing constipation with occasional diarrhea. And patients with this type of change in bowels should also undergo colonoscopy because colon cancer can present with change in bowel pattern. This patient has cancer, and as part of his evaluation, he underwent a PET scan, and the PET scan showed abnormality in the colon, and in that case, we should do a colonoscopy looking for colorectal cancer or colorectal adenomas. Another story, here is a woman who has diarrhea for several weeks, and most often in young people tends to be irritable bowel syndrome, but one should also consider the possibility of colitis. So we looked at several different scenarios where colonoscopy will be useful to evaluate different symptoms and signs. Coming to the therapy, colonoscopy has been shown to be useful in managing tumors, controlling bleeding, dilating strictures, and even removing foreign bodies. So let us look at some examples. Here is a pedunculated polyp, and this can be removed using a snare resection. The snare has gone over the head of the polyp, captured the stalk, and successfully cut the stalk with electrosurgery, and tumor removal was successful in this case. Another patient with bleeding, this is a gentleman who had radiotherapy for prostate cancer, and he started having bright red blood per rectum with hard stools. And when you see this changes in the lower rectum, you diagnose angioectasia or radiation telangiectasia. And this can be treated with argon plasma coagulation, lightly coagulating the vessels. And this tends to control the bleeding. Here is a patient who had colon cancer surgery with colorectal anastomosis that has become tight, resulting in an anastomotic stricture, and this stricture could be opened up with balloon dilation that is successful. Another therapeutic indication for colonoscopy is a patient with colon cancer with mets to the liver and an obstruction, and this could be opened up. This malignant stricture could be opened up with the placement of a stent. So we have learned about indications for colonoscopy. These include indications to screen colorectal cancer, evaluates different symptoms and signs, and also to treat different colorectal pathology. So now let us look at adverse events during colonoscopy. Like any other endoscopy, these patients, when they undergo sedation and go to sleep, they should be closely monitored for effects of the medication on the heart, looking for arrhythmias, changes in the blood pressure, changes in the oxygenation, and also closely monitored for aspiration. In terms of colonoscopy related complications, 3 or 4 things should be kept in mind. 1, when you cut polyps, there is a risk of bleeding. When you perform the procedure, either trying to go to the cecum or during the resection of polyps, there is a risk of injury to the wall of the colon resulting in a perforation. And sometimes, depending upon the anatomy of the spleen, in some patients, a spleen can be injured during colonoscopy, resulting in splenic rupture. It's also important to keep in mind that screening is done to detect colorectal cancer or detect precancerous lesions, and it's important to not overlook lesions. And it's also important to know that certain lesions can hide behind folds and may not be easily visible during colonoscopy. Once the procedure is done, completed without any adverse events, there are certain precautions we need to take in the post-procedure recovery period. And patients are closely monitored during the recovery period. And once the patient is awake, blood pressure, heart rate, oxygenation are stable, not in pain, they are discharged home with certain instructions. And patients and their family are told to call the endoscopy unit or the hospital if they develop any of the following symptoms like bleeding, pain, fever, cough, shortness of breath, or any other bothersome symptom. And we do this to detect adverse events early so that they could be managed promptly. Adverse events could include GI hemorrhage, colonic perforation, aspiration pneumonia, and rarely organ injury, especially splenic injury. So let us talk about aspiration pneumonia. This is a complication when from aspiration during the sedation. And if a patient develops aspiration pneumonia, they can present with the shortness of breath or dyspnea, fever, and if you measure the oxygen saturation, it may be low, and a chest x-ray may show shadows in the lung. And one could prevent this by keeping a suction catheter ready at the bedside and suctioning the throat so as to help the patient and prevent aspiration of oropharyngeal secretions. Another complication is bleeding, which is likely to occur after a polyp resection, and these patients can complain of passing bright red blood, otherwise known as hematochezia. And if the bleeding is too much and they have lost a lot of blood, they can have a fainting spell or a syncope, and the hemoglobin may be low depending upon the amount of blood that was lost. So these patients could be managed successfully with a colonoscopy and controlling the bleed with either a clip or injection of a solution to arrest the bleeding. In some patients where this is not possible or not successful, interventional radiologists may be required, and rarely surgery may be required. Another complication is colon perforation. This can happen during the insertion of the endoscope due to trauma, or during resection of the polyp when the cartilage damage has gone through and through to the wall. In such cases, patient may complain of severe abdominal pain in the recovery room or after they have gone home, and they may also have fever. And whenever a patient complains of pain and fever, they should be brought back to the emergency room quickly, and an X-ray may show air under the diaphragm. If it doesn't, they should undergo a CT scan with contrast to figure out if there was a colonic perforation. These patients should be managed with intravenous antibiotics, nil by mouth, and if the perforation happened during the procedure and there was no contamination of the peritoneal cavity from the contents of the colon, one could consider closure with clips and avoid the need for surgery. In small perforations, in a patient that's otherwise stable, patients could be managed medically, and in some cases, and the radiologist may be required and a surgeon may be required. Another complication is splenic rupture, which is rare. Patients may present with abdominal pain and left shoulder pain And if anybody complains of abdominal pain and left shoulder pain, a CT scan should be done that would identify the problem. And depending upon the extent of trauma to the spleen, patients may require surgery. So I hope this is useful. Thank you.